Hello and warm welcome to MedSynapse podcast series where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host Dr. Smarika Bhatt and today we are diving into the complex world of bone marrow transplantation with Dr. Ankit Jitani. Dr. Ankit Jitani is a consultant hematology and bone marrow at SIMS Hospital. He provides super specialty care for malignant blood disorders like various forms of leukemia, lymphoma, multiple myeloma, and other plasma cell disorders. Welcome to the podcast, Dr. Jitani. We are excited to have you here.
Thank you.
So, without further ado, we'll start with our first question is, can you tell a bit about what is bone marrow transplantation in simpler words to our audience?
So bone marrow transplant is basically a curative form of therapy which is done in broadly two different set of disorder. One set of disorder are all related to blood cancers, where doing a transplant either consolidates the status of remission that we have achieved or it offers a curative potential to the patient. Other set of disease are all the non-malignant or the benign classical hematological diseases like thalassemia, aplastic anemia, etc., where bone marrow transplant is sort of the only potential curative option as of now. There are some diseases in which some form of therapy in terms of gene therapy, CAR T cell therapy are all coming up, but then bone marrow transplant broadly is the only option for cure in many of such disease conditions.
Okay, thank you, Dr. Jitani, for such a clear explanation. Let's move on to the question. With half-matched or haploidentical transplant becoming more common, how do you select the best family donors and how does genetic matching the immune receptors affect the cancer fighting outcomes?
So haplotransplant is a more complex form of transplant. The issue there is because of the half-match status, the outcomes, the complications that happens during the transplants are different. The way we handle the transplant broadly is different. So if you talk about choosing a donor, we always prefer either a male donor or a nulliparous female donor. Donors who have become pregnant, we put them lower down the list because of some reasons. Now, if there is a younger donor available to us, he is preferred over an elderly donor. There is a status of presence of some donor-specific antibodies. Okay, right? The patient should not have any antibodies against incoming donor cells. So those donors against whom donor-specific antibodies are present are not preferred. So that is one category of in selection. We always prefer to have a bone marrow, a blood group matched donor. If that is not available, then blood grouping is not an absolute, contraindication. But we prefer if we find a blood group matched status. The other thing which is not a major problem in our country is CMV status. Most of our population are all exposed to CMV at some point in time. So if the patient is CMV negative, we would want the donor also to be CMV negative. So broadly, if we talk about, these are the categories of donors, and we prefer a young male DSA negative, preferably of the same blood group. CMV is not a major issue in our country. Broadly, this is the story. As about the immunoglobulin receptor, there is something called killer cell receptor, immunoglobulin receptor called KIR. So that offers some graft versus leukemia effect, which can be harnessed in certain malignancies. We do not routinely check for it, but if there is a clear mismatch between the donor and the recipient, there is a chance that the disease for which we are transplanting may see a better control post-transplant if there is a clear mismatch. So it is mostly, as of now, done in research centers and teaching institutes where transplants are done. In most of the other corporate setup, this matching is usually not, as of now, a part of routine practice.
Okay, that was a fascinating overview, Dr. Ankit. So let's move on to the complication part. So graft versus host disease, one of the most serious challenges after transplant. So what new treatments are showing promise for preventing and treating this condition?
So the one of the main issues in doing haploidentical transplant is GVHD, which is graft-versus-host disease. And the biggest advance in haploidentical transplant domain was actually something called post-transplant cyclophosphamide. So after the transplant is done, on day 3, day 4, we give the patient some chemotherapy. The purpose of that chemotherapy is to kill the donor's alloreactive T cells. Those T cells are actually responsible for bringing about graft-versus-host disease. So in haploidentical transplant, post-transplant cyclophosphamide was one advance which actually changed the way haplotransplants were done. It totally changed the outcome. So in the preventive strategy, this PT-Cy, we call it PT-Cy, post-transplant cyclophosphamide, it forms the backbone of transplant conditioning or GVHD preventive strategy. Along with that, we do need to combine a calcineurin inhibitor, which may be either cyclosporin tacrolimus, and along with that, a third drug called mycophenolate mofetil. These three forms broadly the backbone. There are now strategies using ATG, rabbit ATG, in the conditioning part of the transplant to reduce the risk of GVHD. It is one of the preventive strategies which are used by some centers. Along with that, there are now newer advances in forms of using some amount of bendamustine in the post-transplant setup. Drugs like abatacept have also come in. And we also have the option of now depleting the T cells, the bad T cells, before we infuse the stem cell in the patient. So this is known as T cell deplete transplantation. There is a whole setup needed for this procedure, and it does cost some money. But in benign diseases like thalassemia and so, where we do not want a very high risk of GVHD, this is one strategy which has made haploidentical transplant available to a larger set of population. So broadly, these are the preventive strategies that are being used. As for the therapeutics, steroid has been the backbone of GVHD. Once it happens, it is not an easy disease to manage. Broadly, GVHD is divided into acute and chronic. Acute occurs early, chronic is a late complication. So a drug called Jacabi or ruxolitinib is a new addition. I would not really say new, because it is there with us for almost half a decade, more than that. So approved in this indication for almost 5 years now, which is used relatively early now as the second line therapy after steroid fails. Other than this, there are many therapies which were available in the past and still being used in various combination, mixed data, mixed results. There are some drugs, newer drugs, which have come in for chronic GVHD as well. So the GVHD armamentarium is expanding gradually, but there is a lot of unmet need still, and we need to actually get answers to many things once our second line strategy fails.
Thank you so much, Dr. Ankit, for touching upon the strategies and the therapeutic part of the drugs. So we'll move on to the next question, that is, how do you balance preventing versus promoting treating virus reactivation after transplantation? So which approach works best for viruses like CMV and EBV?
So CMV viremia is a major problem. Almost in our country, I have not yet seen a transplant in haplotransplant especially, in which CMV do not reactivate. So we have to deal with it. The problem is when the reactivation happens, the drug that we use to target the CMV take a toll on the bone marrow and on the kidney. And these two are very fragile organ and very important organ in the immediate post-transplant period. So once CMV comes in, the drugs comes in, the bone marrow graft unsettles, creatinine goes up. There are some other medications also which are being used, some of them to prevent GVHD. So all those also have a toll on the kidney. So, it complicates the situation too much. CMV also, the reactivation many a times happen in a background of GVHD when the situation is already tight. So one important drug which is now available to us in our country is called letermovir. This is one drug which is being used as a preventive strategy. We start the medicine immediately post-transplant and we try to continue it as long as possible, not less than 100 days, because that is a period which we want to see through. An expensive strategy, but it is a very welcome addition if after post-transplant cyclophosphamide there is one thing which have actually changed the way haplo will be looked at is the advent of letermovir. This is a very welcome addition. Other than this, most of the medicines which we use are all used to treat CMV. This is a preventive strategy. So for treatment, we have drugs like valganciclovir, ganciclovir, cidofovir, foscarnate. There are some CMV specific IVIG which is not available to us readily. We use broad IVIG. So broadly, these are the things which are available to us. It is not easy to use them because there are lots of other issues ongoing when CMV comes up, and trying to manage CMV takes its own toll. So broadly, these are the options that we have for treatment and for prevention.
Okay, thank you, Dr. Ankit. That was a very well put together answer. So we'll move on to the next question is, what long-term health issues should transplant survivors watch for, and what follow-up care do you recommend catching these problems early?
So the most important post-transplant issue is basically relapse of the disease for which transplant is being done. So we monitor the chimerism, that is how much of the donor cell are present in the recipient cell periodically, and this goes on for a long period in time with variable frequency. Initially, the frequency of looking at all these tests are higher, and gradually we come down on that. We do look out for the disease relapse by doing marrows periodically if needed, and if there is a molecular marker that can be monitored in the blood, we use that to monitor it. Long-term toxicities of the conditioning drugs that we have given, or radiation which has been used as a part of conditioning regimen in transplant, the long-term toxicities in terms of secondary malignancies, thyroid issue, cardiac issues, leak kidney issues, all those needs monitoring periodically. Chronic GVHD is something which is a late complication, can happen anytime, in the delayed part as well. So that is something which we have to watch out for. Chronic GVHD can impact any organ of the body, just like an autoimmune disease. So accordingly, the organ system has to be evaluated periodically. So what we do is, initial 100-month is a very tight, close follow-up. Thereafter, we go a bit relaxed in malignant diseases. In benign diseases, the tight follow-up is up to 200. And then we prefer to see the patient, every month to 3 months initially, gradually relaxing the follow-ups to 3, 6 months, and then 1 year. If the patient is an Indian patient and they have access to us, we would like to keep seeing them for the next 2 years, maybe every 3 monthly. If the patient has traveled from abroad for transplant, this is not an option available. So maybe 6 months to 1 year is a timeline when we would actually physically want to see them. There are some vaccinations also which comes into play, usually starting at 6 weeks. Most of 6 months, most of the vaccines are given at 1 year. So those are all given to prevent the infective complications that can happen as a part of delayed complications of transplant. So all those things also comes in. So that's what we actually look out for in the post-transplant setup. And then there are some secondary malignancies post-transplant. Lymphoma is happening, so secondary malignancies are also an issue in the long term follow-ups.
Thank you for addressing the watch for list. So we'll wrap up the session with one last question is, could you share a challenging case from your practice that has a significant impact or taught you the important lesson about transplant complication?
So I would actually share 2 cases. Both are ongoing. We have the patient admitted. So the first is a young kid who underwent a haplotransplant. Unfortunately, back home, the child got readmitted with diarrhea. We picked up Clostridium difficile diarrhea. It was a C. diff diarrhea. Somehow that coincided and triggered a GVHD. The patient had refractory GVHD, not responding to steroids, also passing blood in the stool. We started the patient on Jakavi, ruxolitinib. Today is day 14. We also introduced a third agent, sirolimus. At this point in time, the CMV started to show up because of all these immunosuppression. CMV is being managed. The bone marrow graft takes a toll if all these things happens together. Because of the drug used to treat CMV, the bone marrow graft is a bit, in a side where it's not totally failing, but it's a bit shaky there. So we are trying to taper the steroid, but once we go down the steroid, the volume of diarrhea goes on to increase. So these are all tricky situations which most of the transplanters face. These are very tough, challenging issues. It is not a very uncommon issue, but navigating through such cases is extremely challenging. So we are actually struggling since last almost 2 weeks, and I hope the patient is better, much better. We probably may discharge the patient in a couple of days, but the GVHD is going to last and keep troubling us. So that is one case. And the second patient, it's not a haplo, but it's a MAC sibling transplant aplastic anemia who got admitted with a fungal pneumonia. So very severe aplastic anemia, hardly any ANC, high grade fever, a big patch of consolidation in the lungs. We didn't have an option but to transplant her. The fever was not coming down despite all aggressive therapy, granulocyte. So with all good counseling, we actually transplanted the patient. Today is day 7 of transplant. Issues do arise. There has been cardiac complication, possibly because of one of the medicines which we have used in the conditioning. So we are fighting hard to navigate it. The saturation had dropped. There are a lot of pulmonary infiltrates. We felt that probably pulmonary edema or sort of ARDS kind of a thing has developed, which was triggered almost 36 hours back. She is better now, but there is a long way to go. We are eagerly awaiting engraftment. So all these things we do get to see across most of the transplant centers in the country. So these are the two complicated cases which are right there in our unit amongst the 4 cases that we have at present, which I had shared with you.
That was quite thrilling experience we have got. I hope that the people who are watching our podcast will get some valuable insight from the discussion we had. Thank you so much, Dr. Ankit, for joining in today with us.
Thank you.
So, and thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join a MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can participate with meaningful discussion or continue to the ongoing evolution of healthcare. And so until next time, stay healthy, take care.